Assalamu alaikum. My name is Rawa Muhsin. I'm a surgical pathologist, and inshallah, I'll give a brief talk about the pathology and pathogenesis of gastric cancer. Let me take this first. Okay. Well, my seniors and teachers have already discussed many of the aspects about the anatomy, physiology, and even the pathogenesis of H. pylori, so I'll not go into too much detail about these. But I just wanted to focus on one thing, which is the region of the cardia and the rest of the stomach, as that is important in the discussion of proximal and distal gastric cancers. We heard many different forms of incidence and prevalence of gastric cancer. Actually, the first one that I checked in UpToDate said that the gastric cancer is the 6th most common and the 4th most common cause of cancer mortality. But then I went back to the WHO GlobalCan 2022, and the current one, which is from 2022, is that it's the 5th most common worldwide and the 5th most common cause of cancer mortality worldwide. Now, the majority of gastric cancers are clustered in Asia and mostly in East Asian countries, especially Japan. Iraq, which is considered to be among the countries of the Asian continent, has an age standardized incidence rate of 5. This is considered to be a low to intermediate risk, not of the high risk like in Japan and Korea. There is a difference in the between the high-risk countries and the low-risk countries in the type of gastric cancer that they have. So in the high-risk countries, which are mostly the East Asian countries, they mostly have the intestinal type, which we will talk about in more detail later, and they're usually distal gastric cancers. Whereas in the low-risk countries, they are usually of the diffuse type and more proximal. Males are affected twice more often than females, although this also varies according to the country. Now, the risk factors, as Professor Dr. Mohammed has already discussed in detail, the major risk factors, H. pylori, we'll talk a little bit more about this shortly. As for the other risk factors, there is a difference between genetic and familial risk factors. When we say familial, it means it's within the same family. It doesn't have to be genetic. Why? Because people living in the same house are more exposed to the same environmental risk factors, so they may share H. pylori infection among them, even if they don't have a genetic predisposition. As for the genetic risk factors, these are two types. First, we have the polymorphisms in genes. These are things that you cannot detect with a simple genetic test. You have a polymorphism in some genes like the interleukin-1 and others that we'll mention. These will increase your risk for developing gastric cancer if you have H. pylori infection. The second type of genetic risk has to do with specific gene mutations that you can detect with simple tests, relatively simple, and these increase your risk of developing gastric cancer directly without modulating your body's response to H. pylori infection. These include the hereditary diffuse gastric cancer syndrome, which is due to a mutation in E-cadherin gene. These patients have an increased risk of developing diffuse gastric cancer as well as lobular carcinoma of the breast. There are other syndromes, but in general, these constitute less than 5% of all cases of gastric cancer. As for the environmental risk factors, we have smoking. Smoking mainly acts through potentiating the effect of H. pylori infection and the risk of developing cancer within the context of H. pylori. As for diets, the diets, mainly meat and fish, and especially salted foods, these increase the risk of developing cancer through the formation of N-nitroso compounds. And this also is one of the mechanisms that H. pylori uses, let's say, to increase the risk of gastric cancer, because H. pylori changes the microbiome of the stomach, allowing the growth of other bacteria that result in the formation of these compounds. As the prevalence of H. pylori is going down worldwide, especially in developed countries, other risk factors are coming up in the development of gastric cancer, mainly autoimmune gastritis, especially in young females, and we will touch briefly on Epstein-Barr virus at near the end of the lecture. This is the pyramid of the Mediterranean diet, which is supposed to protect against gastric cancer because you consume less red meat within a month, and you consume more vegetables and bread with regular hydration. Now, as we said, the main risk factor for the development of gastric cancer is H. pylori infection. This is a histologic picture of the stomach. This is a high-power view. This is one of the gastric glands here. And you can see these small, tiny, elongated rods. These are H. pylori organisms. We wish we could see as many organisms in all biopsies, but usually we don't, and we have to look for like 10 to 15 minutes before we find an organism. This is one of the florid cases with a heavy load of infection. Now, H. pylori infection is responsible for about 90% of all the non-cardia tumors. Remember that the purpose of the image at the beginning was the distinction between cardia and the rest of the stomach. Now, for the cardia tumors, there is a lower association between H. pylori and the development of cancer. It's mostly with the distal gastric cancers. And it's mostly associated with the intestinal type rather than the diffuse type. We'll mention the difference between these two later on. As I said, H. pylori acts through modulating the pH of the stomach. It makes it more alkaline. This will allow the development or the growth, the overgrowth of other bacteria, and these will result in the formation of carcinogenic substances, or yes, in the carcinogenic substances. We mentioned this about, okay. Now, there are two important points here. When you get H. pylori infection, do you have a 100% risk of developing gastric cancer? No. It's only less than 5%. Why is that? This has to do with a number of factors. First is the genetics of the organism itself, meaning, as our seniors and teachers mentioned, you have different pathogenic strains of H. pylori. If you have the cytotoxin-associated gene positive strain, or if you have the vacuolated cytotoxin S1M1 strain, these have a higher risk of developing gastric cancer. So the first one is the organism itself and what strain it is. The second one has to do with your genetic makeup. As we mentioned, there are polymorphisms in genes that modulate the body's response to H. pylori infection. So if you have those polymorphisms in these certain cytokines and receptors like interleukin-1, interleukin-1 receptor antagonist, and others, then when you get H. pylori infection, you have a higher risk of developing gastric cancer. Now, these are things you cannot control, you cannot test for, but there are studies on them. The third thing has to do with the environment, which we mentioned is mainly smoking and diets. So these are the risk factors that determine whether when you get H. pylori infection, you have a higher risk of developing gastric cancer or not. H. pylori acts through a cascade, as Dr. Dana mentioned in his lecture. This is known as the Korea cascade. So the first thing, you get H. pylori infection usually in childhood in the third world countries. And then you either end up with simple non-atrophic gastritis without further progression, or after the non-atrophic gastritis, you progress into multifocal atrophy, intestinal metaplasia, dysplasia, and cancer. And as we said, there are multiple factors which determine which pathway you go: the strain of the H. pylori, your genetics, and the environmental risk factors. All right, so this is the cascade that we mentioned. Now, some points about these components of the cascade. So atrophy refers to a reduction in the number of the glands within the stomach, the normal glands. So this is either due to loss or due to their replacement by metaplastic glands. Intestinal metaplasia, this is an example okay, this is a normal stomach. This is the lumen on top. This is the surface epithelium. These are the gastric glands. This is normal. Here, the difference may be difficult for non-pathologists to spot, but you can see a difference in the lining of these glands. This is more like colonic mucosa. When we have a type of change that almost looks identical to the colon, we call this a complete type of intestinal metaplasia, meaning we have absorptive cells, we have goblet cells, we have Paneth cells. This increases the risk for gastric cancer, but it is lower than the risk which is associated with incomplete metaplasia. This one doesn't look like colon. It neither looks like the colon, nor does it look like normal stomach. It's somewhere in between. We have goblet cells, we have gastric foveolar cells remaining, there are no absorptive cells. This is associated with a higher risk of gastric cancer. So we make a point of mentioning which type of metaplasia we have in our gastric biopsy so that the clinician is aware of the risk. Now, in this particular case, the pathologist in the audience will notice that beneath the incomplete metaplasia, there is an area of high-grade dysplasia that has developed. There is another form of metaplasia I'm not going to discuss in detail. This is called pyloric metaplasia. I usually see this in cases of autoimmune gastritis, meaning it's not of the intestinal type, but it looks like the pylora. So you're within the body of the stomach, the corpus, which has a different histology than the antrum. But you see that you have a loss of the oxyntic glands, the parietal cells, and they are replaced by glands that look like they are from the pyloras or from the antrum. This has been studied in animal models and has been shown to be associated with a higher risk of developing intestinal mild gastric cancer, but in humans, it's still under study, not proven. As for gastric dysplasia, just like in the colon, we can have flat dysplasia or we can have a mass, a polyp. If you have a polyp, you call it an adenoma. Just like in the colon, we have tubular adenomas. But if it is flat, it's not called an adenoma. Other than the cascade, which we mentioned, which results from H. pylori infection, there are other risk factors for developing dysplasia by itself. So there are different forms of polyps, including large hyperplastic polyps, syndromic fundus gland polyps, and hamartomatous polyps. Even if you don't have H. pylori infection, you can develop dysplasia within these polyps, and you can develop gastric cancer. So, so as a summary, these are the important points that we mention in our gastric endoscopic biopsy reports, because most of these have to do with the risk of developing cancer. So we have the presence of H. pylori, the form of inflammation, the presence of atrophy, the type of metaplasia, dysplasia, and other findings. This was one of our cases that we had. It was a large hyperplastic polyp in an elderly female. This is the normal appearance of the hyperplastic polyp. We have these cystically dilated glands, and then we have this edematous inflamed stroma. This is benign, but then within the tip of the hyperplastic polyp, there was this area of low-grade dysplasia. You can see that the glands are more crowded, they're more hyperchromatic, and then there was adjacent to it an area of high-grade dysplasia and even areas of microinvasive carcinoma. So this was a hyperplastic polyp developing an invasive adenocarcinoma within its tip. The patient had a follow-up endoscopic resection of the base of the polyp, and it was negative. The margins were negative even from the start. Okay, so coming to the staging and the spread, or the extent of gastric cancer, there is a division into early gastric cancer and advanced gastric cancer based on the level of invasion. So this is a histologic view of the stomach. This is the lumen on top. This is the mucosa, this fold. This is the submucosa. This is the muscularis propria, and then we have the serosa down here. This line separates early gastric cancer from advanced gastric cancer. It doesn't have to do with the lymph node metastasis. It's only with the depth of invasion. Now, why do we make this distinction? Well, because there is important prognostic difference between the two. For early gastric cancer, if you resect the tumor, whether endoscopically or surgery, I'll need more time, whether endoscopically or surgically, then you have a 10-year survival even of 90%. So it has very good prognosis. Now, whether you resect it endoscopically or surgically has to do with criteria that the GI colleagues know better and they apply. So it has to be node negative, it has to be well differentiated, confined to the mucosa, without lymphovascular invasion and small, to resect it endoscopically. It's important even in these cases to treat for H. pylori to decrease the risk of metachronous gastric cancers, meaning cancers that will develop later on in the rest of the stomach. This is an endoscopic view. I don't know anything about endoscopy, but this is a form of early gastric cancer. It's a polypoid lesion. This is with chromoendoscopy, which allows better delineation of the lesion. As for advanced gastric cancer, it has a much worse survival. It's a 5-year survival of about 20%. These are various examples in the Borman classification. So this is the polypoid lesion. This is a fungating ulcerated lesion with a well-defined margin. This is an ulcer with an ill-defined margin here. And this is diffuse infiltration throughout the gastric mucosa, or the gastric wall, which is known as linitis plastica. We mentioned the now, of course, why do we even stage gastric cancers? What is the significance? So we said this is early gastric cancer down to T1b, which is the submucosa, and then below it we have the advanced. And we also stage the lymph nodes. These are regional lymph nodes. Why do we make this? Why do we bother to do the staging? Well, because there is a clear difference in the survival of the tumors. So if you have a stage 1A, you can see that there is a this is 5 years. This is 1,825 days. So there's a 5-year survival of more than 90%. But if you have a stage 3C, then it's a 5-year survival of about 20%. That's why we stage. As for the biopsy technique, if you take at least 7 biopsies from the edge of the ulcer, then you increase the sensitivity of detecting your neoplastic lesions up to 98%. Whereas if you take only a single biopsy from the edge of the ulcer, then the sensitivity is only 70%. If you have a risk of perforation, then you can take brush cytology from the base of the ulcer, and this will increase the sensitivity for detecting the tumor. And now we come to the meat of the subject. This is the beginning of my talk, which is the histology classification. Now, the most widely used system, which has been around since 1965, is the Loren classification, which divides it into two main types, which is the intestinal type and the diffuse type. Now, why did they make this distinction? Well, because there is a clear difference in the biology and the epidemiology of these two types. Now, this is a histologic picture of a mixed tumor. So here on top and right, we have the intestinal type, and below here we have the signet. Now, why do we call it intestinal? Well, you can see these rounded structures. All of these are glands. So this is a glandular form, or this is the intestinal form. While here below, you don't have glands. You don't have these tubular structures. Rather than you have these individual cells, which look like signet rings. You can see the cytoplasmic mucin and the nucleus at the periphery. Now, what is the biologic difference between the two? It's a loss of the E-cadherin protein, or a mutation in the E-cadherin gene. And we can demonstrate this with immunohistochemistry. So this is an immunohistochemical stain for E-cadherin. You can see that it's retained or positive in the intestinal component, whereas it is lost or negative in the signet ring cell component. This means that this component has lost E-cadherin. Now, why is that important? When you lose E-cadherin, the cells become discohesive, meaning they don't grow as cohesive sheets, as glands. Rather, they are more infiltrative. And that is why there is actually a difference in the pattern of spread between diffuse gastric cancer and intestinal. Intestinal tends to spread hematogenously, whereas the diffuse gastric cancer tends to invade into the adjacent organs and into the peritoneum because it's more discohesive. I need 5 or 10 minutes, 5 more minutes. Okay. The diffuse type has a worse prognosis, whereas the intestinal, it's in older patients. Okay, because I'm out of time, I'll try to be quicker. Now, currently, we don't use the Loren classification. We rather use the WHO classification, the 2019 edition. This has, why did they make this distinction? Because when you say intestinal, you imply that it has to be of intestinal morphology, but that's not always the case. It can be of gastric mucinous type, it can be of null type, it can be mixed types. So they did away with the intestinal terminology, and rather they have classified it into tubular, papillary, mucinous, and the diffuse into poorly cohesive. This is a type of tubular. You can see all of these tubular structures. This is papillary. You can see finger-like papillary projections. This is mucinous. The tumor cells are within pools of mucin. This is the poorly cohesive type, which is either of the signet ring cell or the non-signet ring cell type. And then we have special subtypes. These are rare. Most pathologists will probably not see this in their lifetime, or maybe once or twice. Just very quickly, we have carcinomas which are associated with EBV infection, like we mentioned. بس فين دقائق.
ما شاء الله معلومات الزور
I have a few more about immunohistochemistry and molecular.
You have just half a minute.
We're ahead of time. We're ahead of time. So EBV is associated with different cancers in the nasopharynx. It causes lymphomas, and it also causes a form of gastric cancer which is known as carcinoma of lymphoid stroma, which we can demonstrate with in situ hybridization. This is hepatoid. I'll just skip these because we're out of time. These are rare subtypes. This is a form of cancer in which you have two components. This is the glandular or adenocarcinoma component, and this is the neuroendocrine component. This usually has a worse prognosis, which is determined by the neuroendocrine component. We can stain for that. This is an important point. So when you have a metastatic cancer, the clinical colleague will ask us whether we can confirm this is from gastric origin or not. We cannot distinguish between gastric, pancreatic, and biliary tree origins currently with the immunohistochemical methods that are available. We can just say that this tumor has a gastropancreato-biliary profile, but we cannot make further distinctions because there are no specific markers for the stomach. I'll have to skip these. One final point about the molecular subtyping. The Cancer Genome Atlas has divided gastric cancers into 4 main types. So the genetically stable, this is the poorly cohesive type. It is the worst prognosis. The EBV positive, this has the best prognosis. And then we have the microsatellite unstable and chromosomal unstable. Now, there is a clear distinction in the prognosis between these types. If you have the EBV positive molecular subtype, this has an excellent prognosis, but or a better prognosis, whereas if you have the genetically stable, it's of poor prognosis. We don't test for these routinely because they are only of prognostic value. If the oncologic colleagues request us, we can actually bring these tests. These two are widely available, and we only need 4 tests to determine the molecular profile. Finally, we have 3 molecular targets, which are important therapeutically. Meaning if you detect this molecular change within the tumor, you can actually do something about it, give treatment for it. One of them has to do with HER2 overexpression. Similarly to the breast, about 10 to 20% of gastric cancers are HER2 amplified or HER2 overexpressing. You can use trastuzumab in advanced cases, unresectable recurrent metastatic disease. If you have HER2 positivity, we can stain for it by immunohistochemistry. The other point has to do with PD-L1 and a mismatch repair deficiency. If you have PD-L1 overexpression in the tumor, then you can give pembrolizumab or other drugs that the oncologists know better. And if you have mismatch repair deficiency, again, you can give PD-L1 blockers. I skipped a lot of it because of shortage of time. The take-home messages: H. pylori is the main risk factor. It's important to report all of the components in the cascade within our gastric biopsies. Intestinal diffuse with two main types. We cannot use immunohistochemistry to say that this is of gastric origin in the metastatic setting. We can just say it's upper GI pancreatobiliary. Molecular subtyping is only of prognostic value currently, so we don't routinely test for it. The only therapeutic molecular targets are HER2, PD-L1, and mismatch repair deficiency, and thank you.